Good afternoon, Penn Staters, and thank you for joining us. I'm Paul Clifford, CEO of the Penn State Alumni Association, and I'd like to welcome everybody today to today's virtual speaker session. As many of us are transitioning to living, working, and learning remotely, the Alumni Association is ensuring you stay connected to one another and to the university, and also to stay informed. Today's event with Dr. Matthew Ferrari will cover the two biggest misconceptions of COVID-19, and today's discussion is the first of a recurring series of virtual programming that the Alumni Association will bring to the Penn State community. We'll be speaking with experts, university leaders, and other Penn Staters who will share insight and perspective with you in the coming weeks and months. Additionally, the Penn State Alumni Association offers a host of online networking events, career programs, and webinars, and you can view a full list at alumni.psu.edu/events. Now I'm happy to welcome Dr. Ferrari, Associate Professor of Biology at the Penn State Center for Infectious Disease Dynamics. His research focuses on the application of mathematical models and quantitative epidemiology to guide vaccination policy for childhood infections. For over a decade, he has worked with the World Health Organization, the U.S. Centers for Disease Control and Prevention, and Doctors Without Borders on vaccination planning and outbreak response for measles around the world. Dr. Ferrari will discuss the two biggest misconceptions of COVID-19, and he'll also answer a few questions. You can type your questions using the Q&A function if you're watching on Zoom, and if you're viewing this on Facebook, you can leave your questions in the comments. We'll monitor those questions as they come up and get you as many of them as time allows. Thank you for joining us, Dr. Ferrari. How are you today?
I'm doing well. I hope everybody's staying safe and healthy and sane through all of this.
Absolutely. I'm going to turn it over to you now.
Absolutely. So just, I did want to just give a little brief background or an expansion of background on where I come from and what my perspective on this particular outbreak is. So I've been studying infectious disease epidemiology for quite some time, but I'm not a coronavirus expert. In fact, most people in the world weren't coronavirus experts until this particular outbreak took off. But what I have done is spent a long time trying to study the quantitative data and quantitative information that comes in as we monitor either the incidence and distribution of endemic diseases, so things that we're trying to get rid of, or diseases that tend to occur in outbreaks, so things like measles and meningitis and cholera that tend to erupt in outbreaks, and we oftentimes then have to respond really quickly and reallocate resources and try and evaluate whether or not the interventions that the public health interventions that we're making are being effective, and how can we learn from those interventions to move forward so they can be more effective going ahead. And that's very much the story that I'm seeing in this current outbreak, where very much of the world was really caught somewhat unawares by the severity of this outbreak. It didn't behave in quite the same way that previous emerging outbreaks have happened, things like MERS and SARS and even Zika virus, some of these things that have been large on a certain scale but haven't quite affected the world on the scale that we're dealing with now. And really what we're seeing is both an enormous human toll in terms of the health consequences of this outbreak, the people becoming ill and dying, as well as enormous social, cultural, and economic impacts from the interventions themselves. And everyone is trying to balance their understanding and their appreciation of those two sets of risk, and very much are looking to the data to try and get an answer to one of two questions. Right? And these are the two questions that I've spent a lot of time talking to folks about, trying to help them interpret both what is happening now, which seems like a simple question. We should be able to look at the numbers and know what's happening. But what is happening now, and what will the future hold? What is the future likely to look like? Right? And I think we can draw from experiences that we've had elsewhere to help us to understand what the challenges are in interpreting those two things. So the first question is, what is happening now? how many cases are there, how fast is it moving, and what is the risk that we're seeing around the world. And this is somewhere where I see there's been some enormous challenges in trying to interpret the data that we're seeing coming in from around the world. And there's been a lot of discussion about the data and quantitative information that we're seeing, right? So just to start with, what I have on the screen here now is the number of cases reported each day in Pennsylvania up until Sunday evening when I made this graph, right? And you can see that the number of cases per day is rapidly expanding. So we're seeing exponential growth. The number of new cases each day is greater than the number of cases the day before, right? And that can be a really disconcerting figure. It's quite frightening because it implies that the risk is rapidly accelerating. But it's also quite disconcerting given that so many of us are participating in this this large social experiment of trying to flatten the curve and taking on the costs and burdens of these physical distancing measures that we're hoping are going to slow this thing down, right? But I think one of the biggest misconceptions that I've found in talking to many people is that the numbers that we're counting today, many people perceive that reflects the interventions that are currently in place. And the truth of the matter is that we're actually watching this epidemic like it's on a tape delay, where the numbers that we're seeing now are a reflection of phenomena that occurred in the past. And I just want to step through what that means. So if we take the number of cases on Sunday, right now in Pennsylvania, we have about a 7 to 10 day testing lag, which means that those cases were recorded as positive cases, but they presented to a health clinic 7 to 10 days before when a sample was taken and then sent to the lab. Right? And this again is because this is in part because this is a new virus. We didn't have the testing infrastructure in place to begin with, and we're only rapidly ramping that up, right? So in fact, these cases that we're seeing today don't reflect the transmission and the risk today. They reflect some of the risks several days, over a week in the past, right? And in fact, when you go for testing, that usually doesn't happen on the instant that you become ill and the first day that you start experiencing symptoms. Most people start getting sick, feel a little bit more sick, and then seek care. So in fact, it might be even a few days before that the infection event happened. And then for this particular virus, there's a 5 to 7 day pre-symptomatic period where people have been infected but aren't yet expressing symptoms. And so in fact, the cases that we're counting today reflect risk and an infection event that occurred almost 2 weeks or more than 2 weeks ago. Right? So this is what I say when I say we're watching this outbreak on a tape delay or with a big lag. Now, if you think about that, that means that the people that we're counting today were infected somewhere at the end of March and about the third week of March, very likely, right? And of course, the big behavioral interventions that were put in place, the closure of businesses, the closure of schools, et cetera, in Pennsylvania, weren't rolled out until several days later. So non-essential services were shut down on or about the 23rd of March in Pennsylvania, right? So we're actually still counting cases that were being infected before those closure events were put in place. And we shouldn't really expect to see much of an impact of those interventions until perhaps a few days from now. And in fact, there is some hopeful indication that the number of cases per day is slowing now, which would be consistent with finally seeing the counting process catching up to the time lags that we have that we're dealing with, right? And it also means then that our experience today and all the hardship that we're each taking on by staying home and not going out, not seeing our friends, is very much not going to be seen in large part for another 2 weeks out into the future, right? So unfortunately, what this means is that we have to actually maintain a level of vigilance and a level of patience to be able to evaluate whether or not these interventions are being effective. And so it's the data that's coming in now that's really going to tell us what was being effective 10 days to 2 weeks ago, right? Now, there are ways that we can try and accelerate that process. We can't do very much about the kinetics of the virus. It's going to cause infection and take a certain number of days to make you symptomatic one way or the other. But what we can do is by building health system infrastructure, by making testing more available, more accessible, right? Then we can probably get that testing lag down from 7 to 10 days to maybe about 1 day. And if we make testing more available and healthcare more available, then we can shorten the amount of time between when somebody becomes symptomatic, when they seek care, and when we get a test result that can evaluate this, right? And so actually building these structures and building these systems will allow us to more rapidly evaluate the impact of the impact of these interventions. And that's going to allow us to be more nuanced in our acceleration or relaxation, hopefully, of some of these interventions that are put in place, because we won't have to wait quite so long to get the proof necessary to tell us that this thing is actually being effective, right? So that's the challenge with trying to understand what's happening now. But of course, the big and powerful question that we all want to know is, when is this going to end? What's the future going to hold, right? And again, I think very many of us can look to the kinds of Hollywood endings that we see in pandemic or zombie movies, where a beautiful or handsome scientist in a lab discovers a fantastic new molecule, and we cut to the end credits where everybody is healthy and protected. But we really need to think about what that would play out like in the real world, and what the systems and challenges that we have to bringing about an end to something like this in the real world, right? So what I've got here is just going to be sort of to lay out a schematic for what the future, what the time course of the future might hold. And I'm not going to put real calendar dates on this, because I can't possibly predict what the future is going to be, but we can certainly identify what the stages of this process are going to be, and what the necessary procedures and systems we're going to have to put in place to make these things effective. So right now, we're starting with behavioral interventions: physical distancing, hygiene, closure of businesses, closure of schools. The reason we're doing that is because it's what we have available. Behavioral interventions have been effective in public health since medieval times, right? And in the absence of new drugs or vaccines or other targeted interventions, this is what we have to rely on. But the goal is to rapidly move away from these things, right? Largely because behavioral interventions are a blunt instrument. They're affecting both the healthy and the ill. And our real goal is to try and identify who the ill people are, and be more specific about targeting our interventions to individuals of high risk and those that need care most acutely. So of course, a really important part of that story is to ramp up testing, right? And specifically what I'm talking about here is virological testing that identifies who is sick now, who has the virus in them. If we can identify individuals that are sick, we can both get them into care very quickly, and that's going to reduce the likelihood of a bad prognosis for that individual, of a bad outcome. But also what we can do is we can help to isolate them more quickly and get them out of circulation, so they're putting fewer other people at risk. So by testing, we can actually do a better job of protecting the healthy from being infected by those that are currently sick, right? So this is something that we've had to rapidly scale up. There have been a number of stumbling blocks along the way, but we're slowly on our way to developing this. And I think we really need to keep the pressure on making testing both more available and more accessible to every person in the United States. Right? And of course, having these procedures and having these tests, part of what this is doing, these behavioral interventions, right? We've heard a lot of discussion of flattening the curve or slowing the spread. What that's doing is we're trying to minimize the rate at which these numbers increase, so we limit the burden on our health system, so we don't overwhelm our emergency rooms and our ICUs in a way that our doctors and health facilities can't handle, which would again lead to secondary, more severe outcomes in each individual patient, right? But also what we need to do at the same time is build up the capacity of our health system, not just to leave it as it is, but we want to build up that capacity so we can do a better job with the existing health infrastructure that we have, make testing more available, make testing more accessible, make treatment more accessible and effective, have more ventilators that can handle this surge of cases that we're expecting to have, right? So actually these behavioral interventions that we're putting in place now are buying us time to build up the health systems that are going to keep us healthy using conventional technologies and conventional therapeutics in the short term, right? Of course, we also want new drugs and new solutions and new therapies here, right? The first path to that is the use of off-label drugs. So drugs that are already currently in production, that already exist in the marketplace, but might be repurposed for treating this particular virus. And there's been a lot of discussion of this. And right now what we're in is a phase of testing those drugs. We need to understand both whether they're effective in treating this particular pathogen and how safe they're going to be, and when we distribute them to large parts of the population, right? There's been a lot of discussion of some of the antimalarial drugs, some of these other new drugs that are available. Many of these have positives and negatives associated with them, and we really need to work out what the cost benefit is, especially if we're in a position where we might be redirecting those drugs from people that currently need them for existing health outcomes and shifting them over to use for this particular virus. But once we've done that effective testing and we can start developing procedures for how to safely use those drugs, then we can start to implement those drugs in the short term. And I think that's the upside of that, is that these are things that are already in production. We already have facilities and factories that can produce these things at large scale, so they can rapidly be made available for large portions of the population, right? Then after that, we actually still want to go back to testing. Testing is going to be really powerful, not just to identify the ill, but improving what we call serological testing, or testing for antibodies. What this does is this allows us to test for people that have been previously infected and now might be immune. What this is going to do is going to help us to understand what the landscape of risk is in the population and help us feel more confident about safely resuming normal operations and perhaps relaxing some of those behavioral interventions overall. If we know that there have been large numbers of people that were infected but experienced mild disease and are unlikely to be infected again in the future, if we understand the scale of that, then we're going to know how many people are still at risk, what portions of the country might we expect to still be at high risk of continued outbreaks. And then we can focus our interventions more specifically in those areas of need and relax those interventions from places where they might be where they might be overly severe, and the secondary economic and social and cultural costs may be too large for maintaining some of those interventions, right? And then of course, we want novel drugs that are going to be specifically targeted at treating this particular virus. Again, we need to develop those, and we're working on those the specific molecules and the specific compounds right now. So that's going to take time, even just to develop some of the candidates. There are some things that are out there, things like remdesivir was an Ebola antiviral that's currently in testing right now and has generated some very positive results, right? But it's still these things first need to be developed, then tested, which is some of what's going on now. And then we have to go through a period of production. These are things that don't already have existing factories for production, don't already have existing supply chains for getting out into healthcare systems. So we actually have to start developing those systems right now and looking ahead to how we're going to do that. How are we going to price these things? How are we going to make them accessible to the people that are most vulnerable in our populations, right? These are all conversations that need to be had now, in anticipation of the day when these things become available. And then we can start to make these things broadly available across the population. Right? And lastly, of course, a novel vaccine. That's what everybody wants, right? I've spent a lot of my time working on vaccine preventable diseases, so I'm a bit of an evangelist for vaccines. Vaccines are fantastic, but unlike drugs, they're very, very challenging to test and prove both safe and efficacious. Right? Largely because with a drug, you take a sick person, you give them the drug and they get better. So there's this really nice series of cause and effect that can be seen in the short term. With a vaccine, you take a healthy person, you give them the vaccine, and then you watch them to see if they ever get sick in the future. And that's a much longer process that has to play out. And there's much more rigorous trial design and much more rigorous science that has to be done to prove that a vaccine is safe and effective. So again, these products need to be developed. There already are several candidates that have started in human clinical trials, right? But then there's this very long period of testing that's required to prove that these things are safe and effective. And so this has to be tested and distributed across huge swaths of the population, tested in different age classes and different risk groups, et cetera, right? To ensure that we won't be doing more harm than good if we take a product to market. Then, of course, we still have to develop the production facilities for making these products available. If you can imagine, we now have an ample marketplace, about 7 billion people on the planet that need this vaccine. But we have to then produce 7 billion doses of this thing, right? And then more doses after that for every new child that gets born into the world. And we have to figure out what the procedures are going to be, how to scale that up, how to ensure that we can distribute this vaccine to everyone around the world who needs it. And only after that period are we going to see the long-term benefit, where we can actually start protecting individuals that have yet to become sick, and being very proactive about reducing risk overall in the population. And it's in that context that we might then start to go back to the behavioral interventions. Once we see that these procedures, maybe we don't have the vaccines or the drugs yet, but we at least can see the future, that we know that these things are in a development pipeline. We already know we have production infrastructure up and ready, and we've already developed the testing capacity to identify where the risk is so that we can distribute these things effectively. That's when we can really start to feel confident about releasing or reducing these behavioral interventions slowly, so we can monitor whether or not there's likely to be a return of this virus in the future, a second wave, a second outbreak, right? And we want to be cautious about that so we don't get caught off guard again if this thing were to return, right? So again, as I said, there's no explicit timeline on the bottom of this, because we can't really tell exactly when these stages are going to happen, but we can mark our progress along this route from the current situation we are now to some sort of staged future where we can increasingly start to relax the existing controls and slowly start to return to normalcy. And for what it's worth, I think hopefully to end this on a high note is that, again, while we don't know what the duration of this time period is going to be, human societies have absolutely dealt with novel infections and novel diseases in the past. We've had to change our behaviors. We've had to develop new drugs, but we've absolutely responded to these things in the past. And it might be very challenging in the acute phase, right? In this acute outbreak phase, but we absolutely have examples that we can rely on that indicate that we will come through this on the back end at some point, and we will absolutely return to a new normal. Something that will look probably very much like the way that society and culture was working before this outbreak happened, but probably with a few subtle changes, maybe some increased recognition of hygiene, or perhaps, as indicated by the stages on this screen, perhaps an overall stronger health system, a better system of testing and monitoring for health, and a larger investment in prophylaxis and preventative care that would actually allow us to have a more efficient and effective response to any new threats that present themselves in the future. So those are the two things that I see as being the biggest challenges and the biggest misconceptions about COVID-19, right? How do we interpret the data that we're seeing now and what is happening now? And the way that we think about what the future is going to hold. This thing isn't going to end on its own. It's going to end because we've put these systems into place. And so we really have to be acting now to generate the future that we're looking forward to. And so with that, I think I'm going to stop this portion of the prepared presentation and open up the discussion for questions.
So Matthew, first of all, thank you for the presentation. We do have a number of questions coming in, and maybe it's good to start right where you finished up. Talk about how long does what is the typical testing period for vaccines, and what does mass testing, whether it's vaccines or some of these other kind of drugs, what does mass testing look like? How would that be implemented?
Yeah, it's a fantastic question, and this is one of those places where you might notice me smiling a little bit, because I get really excited about this science, and it doesn't mean that I'm excited about this outbreak, but I think that the science and the structures underlying this are really pretty fascinating, and they're rapidly changing and developing. So conventionally, there's sort of 3 stages to vaccine development or to vaccine testing. So first, you have to develop a candidate. Then you do what we call phase 1, phase 2, and phase 3 testing. Phase 1 testing is really just a very, very limited safety trial. So that's to ensure that when you put this thing into a human being's body, it doesn't cause harm, right? And that's what's being done right now for the at least 2 candidate vaccines that I'm aware of. I think there might be a third one. There's one in the US, one in China, and I think there's a third one in the UK, and I forget what's the phase 1 trials have been approved, but I can't remember if they've started yet. So that's just in a very, very limited group. And that tends to be in the most healthy people, the lowest risk people, so that we're really balancing, right, the ability to learn about harm and not putting anybody at risk by testing this thing, right? Then if that's effective, then we move to a larger scale safety and efficacy trial. That's again for still a fairly restricted group of low risk individuals that are unlikely to be harmed by this thing. And then we test it. So it's just a bigger number, and then we can look for adverse events and side effects. But then we can also measure their body's response to this thing and see whether or not their body is generating the immune response that would indicate that the vaccine has been protective, right? Now, unfortunately, what's really hard to do is it's ethically challenging to really test whether the vaccine works, because that would mean you'd have to expose a vaccinated person to this dangerous disease. And that's something that we conventionally don't do, right? So what happens is we let those people go back into their communities and circulate for a long period of time, during which we expect that they would be exposed to this disease. And we can come back and look at whether or not the rates of disease that we see among the vaccinated group are higher or lower than we would expect relative to the general population, right? And then the third case is that if we see safety and efficacy in those groups, then we do really broad scale stage 3 clinical trials, which tries to distribute this thing to all the different age groups, all the different risk classes. We test this thing in pregnant women, in immune compromised individuals, right? All of these huge population groups that we really want to understand who this thing is safe for. And again, we have to wait for a long period of time to see whether or not that group has lower disease rates than some comparator group, some placebo group or control group, right? Now, in an outbreak, it's really challenging to do that because we're making some strong assumptions about what that risk is. That risk is changing and fluctuating over time as an outbreak expands. There's actually been some really fantastic work that was done in response to the 2014, 2016 Ebola outbreak in West Africa, and then again, the Ebola outbreak that just happened in DR Congo, where scientists have actually trialed some new strategies for testing vaccines that allow them to access that information and assess that risk in real time during an active outbreak. And they've dealt with some of the statistical and mathematical challenges inherent in doing that, which might be able to shorten the time window over which those trials can be done. Right. So it's hopeful that we can harness some of those additional strategies to accelerate this thing. Right. How long do those things normally take? They normally take years. And I think what we're talking about here is a period of development, probably 1.5 at least to 2 years of testing, and then once vaccines have been validated, then we have a scale up and production period of producing this thing. Now, what we're doing is we're putting some things in place that might be able to shorten certain aspects of that are hopefully going to accelerate this process, right? There are some strategies that are putting in place to make the phase 3 trials faster and more effective overall. And there are already groups like Bill Gates has already promised to invest now in the factories and scale-up facilities that would be necessary to produce those vaccines if and when they're approved. So actually building the facilities even for the vaccines that might not be approved. Right? And then we'll just have to repurpose those and shut those down. So that's going to help shorten some of that window, right? But I think in all reality, the 18 to 24 month time frame that most people are talking about for vaccines is still very optimistic and would be an unprecedented timescale for any vaccine development and any vaccine we've ever seen in the world. I don't think that means we shouldn't try and do it. And I think we have a really powerful opportunity right now to create a new model for how to develop these products so that in the future we can actually be much more successful in scaling up the pace of innovation in the vaccine space.
And so Matt, what should we be thinking when we turn on the news and hear UPMC has developed or is in the process of developing a transdermal patch? What can you tell us about that? How should we be thinking about that based on what you just said and we hear these news reports?
Yeah. I think you should be excited for something that might be in the market 2 years from now. But I also think again, I think there's, the optimist in me is looking at all of these procedures as not just addressing this particular disease, but also creating templates and creating procedures that are going to allow us to accelerate the development of some of these products for other challenges in the future. A transdermal patch-based vaccine is something that hasn't been released in human populations anywhere yet. It's been tested, and there's some tests that have been done in animal models. Been some limited testing in humans, but a transdermal patch is a really fantastic technology that embeds the components of the vaccine inside of a little microarray, this little patch that's got tiny little nanoscale needles in it that you put on your skin, and it melts away. Those little needles just barely penetrate the skin to the dermis, the layer just below your outer skin, and delivers the vaccine just to that layer alone, and then sort of melts away. And it's very clean. There's no blood associated with it. It's not an injection. It can be delivered by, in principle, by a medical technician with less training than somebody that would have to deliver a needle-based vaccine. So it's a really fantastic technology. And in fact, in my world, before the COVID outbreak, we've been shouting from the mountaintops about the need to develop these transdermal vaccine delivery systems for things like polio, for things like measles, for things like cholera, for diseases that affect the most vulnerable populations in low and middle income countries. And because these things are simple, they're cheap, they're light, they require minimal health infrastructure, they oftentimes don't require refrigeration and freezer technology. So they would absolutely massively increase the scale of vaccine delivery for our conventional vaccines all around the world, and hopefully solve a lot of problems and save and minimize the death and disease due to all of these conventional diseases. So again, I think we have a real opportunity to use the current attention focused on accelerated development and accelerated scale up of vaccine production that are then hopefully then going to create a path forward for solving so many of the world's other diseases that have still been lagging behind.
So can you talk a little bit about, or do you have any insight as to why the virus affects individuals differently besides the conditions of the victim? Are there other things that some people point to blood type? Why do some people have this affect them severely and others not?
Yeah, this is a fantastic question. This is really, this is just a rapidly developing area, and I'll admit I don't, I probably can't give a very nuanced answer to this. There are a couple of contributing factors that might give rise to this, right? The first of which is the ability of this virus to recognize the host cells, so they recognize the characteristics of the person it finds it in. And there are some people that have receptors on their cells that this virus binds to very quickly and very easily, and there are other people that there's less binding affinity, or it's less sticky, I guess, right? So we're seeing that there's some variation in human populations across there, and some of that is perhaps genetic. There have been some suggestions of just simply some male-female differences there, right? But there also are going to be environmental differences, and one of the things that we've seen is that certain kinds of environmental conditions, like smoking and air quality, might actually cause overexpression of the kinds of receptors on the cells of your throat and lungs that this virus grabs onto. And so that's been proposed as a hypothesis for why we're seeing more severe disease in individuals with a history of smoking, right? So again, it's an environmental condition that's interacting with the expression of characteristics on your cells, right? And then beyond that, then we're absolutely seeing some of the classic problems that present themselves across all diseases, whether they're infectious diseases or chronic diseases, that are tied to issues of equity in health access and health availability. Right. So one of the things that we've seen with this disease and many other diseases is if you catch it early in the symptom progression, then medical treatment can mitigate the chances of progression to more severe disease. And if you have people that are unable to seek medical care early, or can't afford to seek medical care early, or are afraid to seek medical care early because they're part of marginalized groups that might otherwise be discriminated against. Those are all things that are unrelated to the disease process that prevent those individuals from seeking medical care quickly and effectively. And so therefore, as a consequence of underlying cultural and social inequities, basically predispose those individuals to a much more severe outcome down the road, right? And again, I think these are the kinds of addressing those kinds of problems requires a broad scale set of investments in closing gaps in health access and health equity. That is absolutely something that we know we can do. It doesn't require a new drug. It just requires that we build systems that are accessible to all people.
Yeah. So Matt, can you talk a little bit about, so there are medicines and vaccines that are currently being worked on to develop, and then the behavioral modifications of social distancing and staying at home and proper hygiene. One is focused on an actual cure, or at least some sort of preventative prevention of catching the disease. Another is related to what they're calling flattening the curve. Can you talk about, can you talk a little bit about the behavioral modifications, why they were implemented, and that those are, and kind of the reasoning behind that?
Yeah, absolutely. So there's really, I mean, the simplest answer for this is the best. It was all we had. That was why we went with it. We've relied so heavily on these behavioral modifications. It's the tool that was available. And until we can get a better tool, it's the best thing that we can do. And again, we're focusing on this for twofold, right? There's both the reduction of individual risk. So we're all doing this to protect ourselves and our families, right? We want to keep our people healthy. And not going out into the world is going to help that happen, right? And of course, on an individual level, everybody is going to, if they haven't already, is going to start grappling with the costs and benefits inherent in that. Because by doing that, there are many people that are not going to work, that are facing wage and food and housing insecurity as a consequence of these actions, right? So everybody is dealing with that cost benefit, and that's why I think, again, it's really important that we have both governance structures and institutions try and provide for or try and minimize the barriers to adherence to those things. So providing for paid sick leave, providing for paid leave, these kinds of structural safety nets that we can put in place for people, right? Then the other thing we're trying to do is, again, we're trying to buy time for us to then invest in the health systems that are going to be able to handle the increase and surge in cases of severe disease, right? This is actually something that on a much slower time scale we deal with every year. Every year we know there's going to be a flu season. We know about when it's going to happen. It happens at about the same time every year. And if you talk to a health system administrator, they know how many months in advance they have to start ordering drugs. They know how many masks they have to have on hand for every single health facility. They know how they're going to be staffing their facilities and scheduling to make sure that people's time off and time on is optimized so that the health system can handle that annual increase in the number of respiratory illnesses in the fall and the winter, right? Yeah. This outbreak came at a time when we were on the back slope of that. We had basically burned through all of the stuff that we had in place for dealing with the regular flu season, and all the storerooms were effectively empty. That's nobody's fault, because this thing caught us off guard, right? And so part of what we're doing now is buying time to build those systems back up at a time when they weren't well prepared, because not only the health system administrator has to know how far in advance to order the masks, the mask producer has to know how far in advance to start producing those masks. And you again start creating all of those lags in the health system supply chain. And you can't just immediately start refilling those things because the masks weren't being produced. And again, this isn't necessarily the fault of the people that produce masks. They were working on a regular time schedule, right? And we've completely thrown that to the wind and rescheduled everything as a consequence of this, right? So really what these behavioral interventions are doing is trying to buy us the time to build up the capacity to handle these things using both the conventional measures we have available, and then hopefully these new measures. And really, again, what we're really hoping for is to, through the scale of testing, to be able to change the burden of cost across the population. So these behavioral interventions are disproportionately helping, or disproportionately being felt by the healthy, right? I mean, there's no way around that, right? There are huge numbers of healthy people in the United States that are taking on a huge cost right now, right? That in order to protect the communities that they live in, right? And we would really like to start shifting that over. And what testing allows us to do is to identify the ill quickly, so that we can then start shifting our interventions towards focusing on the ill in the areas where there's highest risk, and then releasing the burden of cost for this on the healthy.
Yeah, a lot of questions coming in. You just mentioned testing as a solution to shifting the burden, but we're still hearing of folks who are showing symptoms that they're being denied the option to be tested. I know as a scientist, you probably want as much data on the backside of this so that you can really study what happened. And yet it seems like there's data that we're not collecting by not testing everybody, or by not testing those who are symptomatic. Talk a little bit about how we can ramp up testing and what the thought process is behind who gets a test and who doesn't.
Yeah, this is a fantastic question. This is a question that's really very near and dear to my heart. So let's be clear. Part of the reason that people aren't getting, that people that want tests right now are not getting tests, is because the tests aren't available. And it's not the fault of the health system administrators that are allocating or withholding tests from any individuals. It's just simply that we have a period of scale up, and we're trying to get to the point where we can provide enough tests for everybody that needs them and everybody that wants them. And we're just not there yet, right? So that's first and foremost. And so that requires, again, enormous, ideally, I think, nationwide investments and a lot of top-down support for producing these things and getting them out and distributing to the places where they're most in need, right? Again, that distributing them to the places that are most in need, again, is a systemic allocation problem. There are parts of the country that need lots of tests right now. There are other parts of the country that need less per capita, right? That's a large scale supply chain and distribution problem, right? This is the kind of stuff that Amazon and Walmart are really very good at, making sure that their shelves are full relative to how people buy stuff, right? And so actually looking to the kinds of scientists that work in supply chain optimization and distribution, right? Those are the kinds of people that have the skill set to solve that problem of, given the number of tests we have, how do we optimally allocate those to the people that are in need, so we minimize that burden and minimize the lags inherent in that. Now, even within that, we can think about what are the dual benefits and dual uses of this testing, right? And the use of testing is twofold, right? For every individual that is symptomatic, the test might help affect their course of treatment, right? So if you have somebody that's symptomatic and you test them and they're test negative, then you know you can get them home rapidly and you don't have to worry about continual monitoring. If they come up and they're test positive, then you know that's someone that you need to isolate in a very specific way. They have to experience more severe and restrictive isolation, and you need to be monitoring them very carefully, especially if they're in a high-risk group for progression to severe or critical disease. And now you've got to be thinking about, do I have an ICU unit available for this person if they go down that road, right? So the testing is really important for the individual. That testing is also really important at a population scale, because local governments and health systems need to know how many people are likely to be sick, right? And so we actually need to be, in an ideal world, balancing the allocation of tests relative to how much, for every given test, we can ask this question. And this is a very academic question, but I think it has a very practical application. For every given test that I've got, I should say, if I give it to this person, how much is this test going to affect the course of disease in that person? And how much benefit is society going to derive from the information I get as a consequence of that test? right? This is one of the reasons that there has been some suggestion that people that have only very mild symptoms not seek testing right now, right? It's because if you're currently mild and you might stay mild, then you can probably manage your course of infection locally and in the home. That means you're not putting anybody else at risk. It's unfortunate you won't know what your disease outcome is, but you're not going to put anybody else at risk, and you're unlikely to take a test away from somebody that might really need it because they're in a much higher risk group, right? That's, there again, we're sort of trading off that individual benefit and risk relative to the amount of information that the population and society needs to be able to track and reallocate for these things. Again, scaling up testing so that we don't have to make those ugly decisions is absolutely the best thing to do. And we're really working on how to sort of balance on that nice edge of what is effective and what is ethical and what is equitable for the distribution of these tests across the population.
Yeah, we have about 10 minutes left here, and a lot of questions pouring in. So I want to ask about 3 or 4 more here.
Okay.
The first 2 I want to ask, I'm going to combine them.
Sure.
It's about numbers. So the past 5 days in Pennsylvania, the daily number of coronavirus counts has stayed at about 1,600. Does that start to indicate that we might be plateauing? And then the second part of that is looking locally here at our Center County numbers. Yesterday, we went from 44 to 55, the largest single day jump in cases. Talk about what those numbers are saying to you.
Yeah. So I'm certainly hopeful. I hope that does mean that we're flattening this thing out. That means that we're going, if the numbers start to even out per day, that means we're going from the exponential phase into a linear phase of growth. So the outbreak is still getting bigger. It's just not continuing to accelerate. And for me, that's the switch between the beginning of the beginning to the end of the beginning of this outbreak.
Right.
And I think we're at about the time scale right now where we hope to be seeing that, which would indicate that the behavioral interventions have been working. I don't want to be too much of a pessimist, but I think it's absolutely worth noting that we're early in the week right now, and the world over, data doesn't get recorded very well on the weekend. And it's an unfortunate reality about the world. Data doesn't get recorded very well on Christmas and Ramadan either, all across the world, right? So I think I'm still very cautiously optimistic about the numbers over the last 3 or 4 days in Pennsylvania, and I really hope that they are in fact stabilizing, and it's not just a consequence of a testing lag and a backlog in reporting of cases that we're going to see jump up over the next couple of days as the tests that came in over the weekend are starting to get processed, right? So I'm hopeful and I'm cautiously optimistic, but again, that's the reality of the world that we live in. And I think we need to again, maintain that vigilance and have some patience to be able to be certain that these trends are indeed playing out. As far as the Center County numbers, Center County, I think, is a really interesting and I think perhaps challenging setting where we're really very low risk overall, both because we've had these physical distancing restrictions put in place. When I'm looking around my neighborhood, it seems like everybody is adhering to these things. So I think we're doing a very good job in maintaining low risk, but we're also at really very low population size right now because the university has been closed. And so we don't have nearly as many people around as we normally do, right? So I think that, a very particular situation that we have to deal with in the Center County region is what the future is going to look like when not only we release these behavioral restrictions, but we also massively accelerate the population size and the population density in our region, right? And what the inherent risks might be associated with that. So we also now, again, need to be using the time we have available now to build in the infrastructure that can handle that potential surge that might occur in the future.
Yeah. A couple more questions here. I want to ask you kind of maybe if you've, and I'm sure you haven't had the chance to extensively do this, but if you were looking back, right, what are some of the lessons that we are going to learn about the next time something like this happens, right? As a country, how could we be more prepared? And what are, if anything, the roles of the health organizations around the world, whether it's the CDC or the World Health Organization or NIH, how would their roles change based on what's happening?
Yeah. In all honesty, I don't think the roles of those organizations is going to change very much, because I think that by and large they've been playing the role that they should be playing. They play the role of both national and international coordinators, ensuring the flow of information and data from country to country. Again, there have been hiccups and missteps throughout this outbreak in terms of data transparency and when countries alert other countries and all of that. However, while those have been challenges, this has been by far the best example of open and transparent data sharing in a large scale national or global outbreak that I've seen in the course of my career, right? So we may not have done it great this time, but we've done it better than we've ever done it before. And I think that some of those lessons, there are lessons to be learned there, and then we should build on the success that has come from that. I think what we're really going to see now is the importance of really strong coordinated federal response and federal integration. So one of the things that we've seen is a real challenge and really a systemic vulnerability of the U.S. system is our system of federalism. So each state sets its own rules and sets its own behaviors, right? Again, these are things that, absent a pandemic, are great, and I'm very supportive of, but they become challenging when you need a large-scale, nationally coordinated pandemic response, right? And so we need a better system of federal coordination for the imposition of controls, distribution, reallocation in states to states that need things, right? So we can take resources from one area, rapidly deploy them to another area. This thing started in Washington, and if there would have been a benefit to the other 49 states of rapidly allocating resources to contain it in Washington so that it didn't spread elsewhere, right? I mean, these are the kinds of strategies that if you have strong top-down federal control, you might be able to implement, right? I also think I think the other thing that we're really going to have to look at some kind of reorganization is coordination among our privatized system of health delivery and health insurance, right? I'm a bleeding heart liberal, so I'm all for single payer healthcare and all of that, right? And my statement here is not a political one about that. It's just simply a matter of the fact that because we have distributed health providers and health delivery, right? They also have a hard time coordinating their response, right? I was on a call with some U.S. Congress members earlier in the week, and they were asking about a strategy that's been proposed where within a city you would designate one hospital to be a COVID hospital and another hospital to handle regular care, right? That makes perfect sense because you can isolate the COVID sick people here and guarantee good provision of care in this other hospital. But in a system where both of those hospitals are owned by separate private companies, then it doesn't work relative to their profit model to be able to do that, right? It's only if you have some structure that can coordinate between them and offset the costs of doing that rapid change, right? That kind of a system works, right? So whether we completely restructure the U.S. health system or not, that's a whole nother discussion to be had. But we absolutely need a system that allows us to rapidly override that individual-based system and coordinate over a large scale when we have these kinds of national scale health issues.
Yeah, it'll be an interesting case study on the other side of this with world health crisis and the confluence of civil liberties and personal liberties and states' rights and federal rights and the for-profit healthcare system and kind of how it was almost a perfect storm for slowing the response to this. Yeah. So let's shift gears and talk about the future. And talk about, so we talked about flattening the curve. We've talked about the backside of the curve, right? What does re-entry look like back to normal society in a post-COVID-19 world? Timelines, business and schools reopening, sporting events, all of us are wondering about Penn State football. Kind of what does that timeline look like?
Yeah. so I've said many times before that that I'm not willing to speak in calendar dates because any prediction I make is going to be wrong. But I think there are two things that we need to be looking at, right? We need to be looking at the case data, and we've already discussed today what the challenges are in interpreting the case data and the death data are because of the lags inherent in those. But that's one of the best things to be monitoring. The other is that we need to be looking at what kind of systemic changes have been put in place for the health infrastructure. I think if we have confidence that we've built up the health infrastructure to handle a potential surge in new cases, then I think then we can confidently go back to work. And we can confidently go back to, return to operations and all of the fantastic things that made our lives happy and fruitful in the past, right? But it's not, so that's what we really need to be looking for is where are the investments in testing and accessibility? Have we got the foundations and the safety nets that will be there if we see a return to cases? And I think we particularly need to be thinking about building these on a pretty rapid timescale, about 6 months, because in the fall and winter, we know we're going to start to see an increase in respiratory illness because it happens every year. And if COVID has waned, that's great, but we're going to start seeing sick people start showing up again, and we're not going to know right away whether that's a resurgence of COVID or just the normal cold and flu season, right? And unless we have the testing infrastructure put in place and then the guarantees that if it's COVID, our health systems can handle the increase in severe cases, and we have the respirators and the isolation rooms and all of those and the procedures in place to help people quarantine safely, to stay away from work, to not face wage, housing, and food insecurity in the event that we ask them as a community to quarantine for our benefit, right? If we haven't got those systems in place, then I would be really cautious about a normal return to operations. But if we build those structures now, then I think that we can go back confidently. And frankly, again, I said I'm a bleeding heart liberal, but I think that we're going to benefit as a society if we have those structures put in place in general, because a healthy society is a robust society. Those are more people that can work. Those are more people that can contribute to economic growth. And I think we all do better in the long run.
That's great. Well, Matthew, I want to thank you for sharing your expertise with us today and with the Penn State community. It's great to have experts like you in our community who could talk about really complex issues in a way that's understandable for all of us, and in a way that we can now take what we've heard from you and go out and make adjustments and be safe and help protect others in our community. And so on behalf of the Penn State Alumni Association, we're truly grateful for you joining us this morning.
And it's been great to have the opportunity to share my experience with everybody, and thank you all for the fantastic questions and the ongoing conversation about this.
Great. That's all the time we have for today. Thanks again to Dr. Ferrari. I also want to thank everybody who has joined us and tuned in to today's virtual speaker session. As a reminder, we'll be hosting additional speaker sessions in the coming weeks and months. And this programming is in addition to a wide array of online networking events and career programs that are available throughout the year. You can view the full listing once again at alumni.psu.edu/events. Thanks everybody for coming out. Be safe, be healthy, and we are